COPD. A couple conflicts of interest, although not relevant to the talk. I do some work for UpToDate, and there's one company, Allegra, that I'm involved in with lung cancer screening, so none of this has anything to do with COPD or related. So basically no conflicts of interest. But the references that I'm going to use for the talk and the slides are three sources. One is from the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD guidelines, which you may have already heard by now. They've been out there for at least a decade. They've been revised several times. And that's really probably the basis, the bulk of the slide, basis for the talk. A website you can go to get this slides plus other information, and at the end of this talk, and they should be in your handout, there are several websites for all aspects of COPD, some smoking cessation, patient education kits, and so on and so forth. Another reference source that I use for this talk is another CME organization called Circulate, and that's an acronym that stands for something I can never remember, and on the slides at the end of this talk it's going to spell out precisely what it is. But again, it's a CME-based organization, and the third reference for my talk are data slides that I've put together over time on COPD for the various talks I've given. So from the GOLD guidelines, this is their definition of COPD, that it is really a systemic disease because there's extrapulmonary effects, and we'll talk about some of that. The lung side of it, or the pulmonary side of it, is characterized by airflow limitation or obstruction, but not fully reversible on spirometry, that pulmonary function test that you do. And that this disease is usually a progressive disorder, and it's related to an inflammatory response to one or more noxious stimuli. Well, for me, I've kind of, in my mind, I kind of put this definition together, because that, for me, wasn't, well, does it really sit in? How does that, I'm a clinician, does that make sense to me? And I think this is how I kind of put it together. Again, this is my opinion, that there's a clinical side of it. Usually they have symptoms and they're chronic. It might be shortness of breath with exertion initially that's progressed over time to even at rest. And they might have a cough, and they may be productive, may not be productive. And then on spirometry, or pulmonary function tests, if you will, in a generic sense, this spirometry is just one of them, you have obstruction demonstrated. It may be partially reversible when you give them that bronchodilator at the time of testing, but not fully reversible. And it's a progressive disease, and in my mind, I've eliminated other disorders where you might be short of breath and have some obstruction on your spirometry too. So it's a differential diagnosis winning. So this is kind of how I look at the definition of COPD. This, you may have seen this diagram before. It can be an overlap. We use the term COPD, and we say, well, what's emphysema? Is this the same disorder? I tend to say COPD, emphysema in the same breath, although we used to think of emphysema as a pathologic diagnosis, a hunk of lung that was in the pan in the lab that had emphysematous change. Then there was chronic bronchitis, which is the chronic productive cough for 3 months for 2 consecutive years. Then there is COPD. Is that different? What about asthma or other disorders with airflow obstruction? So really, COPD is kind of a gemisch here, if you will. And we don't distinguish, at least I really don't distinguish much from these three terms. I kind of lump them together. The differential diagnosis, probably the number one that you're working with is to differentiate COPD from asthma. When you think about sheer numbers, that's probably foremost. Is this an asthmatic? Is this a smoking asthmatic? Or is this somebody who's got COPD? And sometimes that's not so easy to do. And I think in the real world, nobody is all one or all the other. I mean, they're somewhere in between. You know, you used to say, well, COPD, a non-reversible disease. Well, now they're at least saying at least not fully reversible, because you can have some reversibility on COPD. You can have an asthmatic who smokes, who has got asthma. If you take the history, you can go back to their 5, 6, 8 years old, but then they started smoking in their teens, and you've got 2 disorders overlap. And the rest of these I just put on here to give you some idea that, yes, there are other disorders that are going to give you obstruction on spirometry. Generally, you're going to get a history that's a little bit different than what I've just listed, you know, chronic symptoms of those 2 or 3 that I talked about. But you do have to work, like anything. You work down your differential diagnosis. Well, I think he or she's got this disorder. This is to highlight some differences between COPD and asthma. Again, because I think asthma is probably your number one competitor, if you will, to COPD in your differential. Generally speaking, COPD or smoke, about 90% of COPD is going to be from smokers. Asthmatics can smoke too, and we see them. Asthma often it comes on when they're younger, although you can see asthma showing up in the 30s and 40s too. It's not impossible. COPD, it's usually older because I'll talk about it. It's going to take years generally of smoking for the symptoms and the disease to hit them. And asthma tends to be variable or seasonal or daily. There's patterns that can change from being great to being sick. While COPD, generally, they don't flip-flop like that. They can have exacerbations, of course, and get a lot worse, but they usually have some baseline impairment. And for asthma, generally, you consider that to be fully reversible on spirometry. Now, it may not be just after 2 hits of albuterol in the lab one time. You may have to treat them if they're bad enough with inhaled steroids, but this eventually, if you do it right, spirometry will get back to normal. Well, that's not going to be the case in COPD, so there's a difference there. Well, it's a tip of an iceberg in that there's about 2 million people with severe disease, another 10 million that we know of with some less severe disease, mild impairment, and then there's probably a lot of people that we're not even aware of. Either they aren't coming in or we don't, maybe we don't take as good a history, and wait a minute, it's been going on for a while, let's look a little more. The undiscovered population, but a goodly number. I mean, you add those up, and that's a fair number of people to one degree or another. Well, what happens with these people what's their natural history? And that's the yellow line. If you look at that's lung function, in this case it's absolute value, over age. For the people with COPD, they become impaired, and they can't run productive lives. They end up in the emergency room or the hospital or sitting at home in a chair, and then they die early. So loss of life, loss of productivity, impairment, compared to the smoker who doesn't have COPD or the normal person. So that's why why should we identify these people? Well, is there something you can do to move this curve over? I mean, that's the essence, besides make them feel good and move the curve over. Mortality. U.S. Men, women, and this leads through this data through 2005, the women now take the lead, but again, add that all up, and what do you get, about 120,000 a year, give or take? 60 plus for men and women. That's a fair number of people dying from COPD. But they also will die from other causes, and I'll show you those. Of the 6 leading causes of death, only COPD seems to be on the rise. The others, whether it's accidents, stroke, cancer, you can read that as well as I can, they're either flat or decreasing. So it's a problem. What do they die from? Well, some of this might be intuitive. You would think respiratory failure or COPD, and indeed that's true. Most of them are smokers, so what about lung cancer? And then what about other smoking-related diseases? And here they've broken out, at least in this study, atherosclerosis, acute infarct, atherosclerotic cardiovascular disease, heart failure, then all cardiovascular disease, but cardiovascular disease, lung cancer, COPD, infections. So those are the general causes of death. What about risk factors for COPD? Are there any? Well, number one, it's what Dr. J, as Steve had talked about. It's tobacco smoke, whether it's active or passive. That's clearly the number one risk factor. Are there some genetic ones? The answer is yes. There's only one that's probably clinically relevant yet in terms of testing. That's the alpha-1 antitrypsin. There are other genetic things that are in the lab, but they have not been translated yet into some clinical use that you test for and you have some intervention for. And that may come, hopefully. And then there are other factors. We know that indoor heating, if you're going to burn a wood fire in the house to heat your house and cook, which is probably not applicable to most of the United States or maybe developed countries, but is very relevant to underdeveloped countries. That's a known, well-proven major risk factor for COPD. Or you don't have to smoke cigarettes, but if you're heating your house and cooking over biomass for burning wood and whatever, that is. And then there's the rest of these things, the collective, occupational dusts, organic, inorganic, fumes, vapors, what have you, and pollution. But the link or proof of cause and effect, this exposure causes COPD, is not well shown in much of this. There's some now data come out in the last decade looking at various industries, occupations, and with incidence of COPD higher in one and the other, but the proof that exposure to what particulate or what matter in this occupation has caused COPD is not 100% proven, so it's tough if you're going to make cases for disability in court and those types of things. We know that as an asthma, if people work in industries where there are organic solvents on the farm, smoking, fumes, or when we know sulfur and nitrogen-containing air pollutions, that if you have lung disease, you tend to have more exacerbations. People buy that. But to actually cause COPD, that's a different question that's not well sought out yet. And in some cases there are. Things like the coal miners, asbestos mining, silicosis from the miners, those are a little more established. And there's some others, leather industry, some agricultural industry on the farm, the dust, the corn, the silos, those types of things. Leather work, cotton, farming, milling. There's some other things that are starting to come to the fore. But in terms of in your office to take a history and say, oh, you have to quit your job, that's tough for even me to do, and I wouldn't expect you guys to be able to do it. You certainly could ask, and you start to wonder, could some of those be related? Cause? I probably wouldn't get into that. Exacerbated if they haven't? There's some question on some of that. Of course, that's a touchy area, not only in the last 3 years when the economy's tanked, but in general when you start talking about people, well, and even in the cases where I've seen where I'm pretty sure their job is part of the picture. Quitting? That's the only job I got, and I got family to feed. That's a touchy issue to go with. So generally smoking, that would be number one. That's clearly number one and outranks just about anything else. And one you can intervene on. It's going to be tough for air pollution to intervene on an individual in the office. Occupation, there might be some for that. And the usual pathogenesis is going to start with some initiating event, usually tobacco smoke or something else that's going to start an inflammatory process that's going to disrupt either protective strategies in the lung or aggravate or create ones that are destructive, that's going to lead to the pathology. And part of that pathology in some people are the goblet cell hyperplasia. These are the cells that produce all the mucus. So you get more cells, more mucus, but you also get inflammatory cells, maybe some, as smooth muscle proliferation. Down the line you can get scarring that also narrows the airway besides mucus, leading to dyspnea, obstruction on PFTs, productive cough. The other side of it is in the emphysema people, the end game of this pathologic process actually leads to destruction of the lung, the alveoli, and the supporting structure of the airways, such that when they expire, the pressure swings in the chest, the airways basically contract or close down. Besides the hypertrophy in the airway, the mucus, the goblet cells, you can have a mix of all that leads to the pathology. It leads to airway narrowing, the obstruction, and all the symptoms. There is an inflammatory process. It's more macrophage and CD8 based. Asthma is more CD4, eosinophil to some degree, some different cell lines and cytokines. They're both inflammation, not the same, but probably some basis why anti-inflammatories may work better in asthma than in COPD because the pathology is different. All inflammation is not the same, but I'm not smart enough to when you get down on the cytokine level to start figuring all that stuff out. That exceeds my brain power. Well, before we'll shift into what does the GOLD guideline do for management. I mean, once again, it's making sure you got the right diagnosis. The history, usually tobacco smoke, not everybody. There are some people in the group that occasionally I see are the people who never smoked in their life and never had passive smoke. But when you talk to them, they probably had asthma that never got recognized or treated. And over time, they, quote, turn into someone who looks like COPD by history and by spirometry, because they do. That's the end game of untreated inflammation of asthma. You can turn into somebody down the road that looks like a COPDer. And that's it's a hindsight diagnosis. It's by history. There's no, you're not going to go back in a time capsule to prove it. But most time it's tobacco smoke related. Usually the symptoms we talked about. The pulmonary function test primarily we use here is spirometry, and they definitely want post-bronchodilator. When you eventually get into staging and treatment, you're talking about post-bronchodilator. Usually you end up getting both, because if you give somebody albuterol in the lab and they fully reverse, you're not talking COPD, so you don't even want to start going down the pathway of COPD treatment in those people. If if they're sick enough or impaired enough, do you check, a blood gas or walk them in the office with an oximeter? You can do that up front. If you're by history, you're wondering, wait a minute, something doesn't quite sit right here. Do I want to get a chest x-ray or a CT scan? You might see bronchiectasis. You might see something that suggests cystic fibrosis or something else. And that's a judgment in your turn in the office. The gold guidelines don't say do all of this. I'm just adding that in as my opinion. I think you get, again, use your judgment. The bottom line is, though, coming to the conclusion, yeah, I think my patient's got COPD. The clinical features, usually it's about a 20-pack year history for the symptoms to set in, and that's plus or minus. And depending when they start smoking, well, people try to get them as kids and adolescents. So in the teens, add 20, 30 years, you're talking late 30s, 40s, that's the 4th, 5th decade of life. And sometimes they may be people where they're in their office because they're acutely ill. But when you talk to them, they've had symptoms and only now they're worse. They can't shake this chest cold. Well, maybe they probably because they had chronic symptoms that only got worse with exacerbation, and that's the first time you're seeing them, so that's maybe where you're going to pick it up. But with a little bit of history taking, to establish where there's a baseline that's gotten worse, as opposed to all the symptoms came now in the last 2 weeks or week. What might these people look like? I guess, I don't know, maybe I'll get criticized for putting faces on. This might be the guy who's, late 30s, 40s, 20 years, got the chronic cough, hacking cough in the morning that's been smoking, but on maybe no obstruction on COPD. Maybe we would have called him a chronic bronchitic when I had those, not the Venn diagram, but all the circle overlapping kind of diagram. This might be the guy we used to call a pink puffer, cachectic, the emphysematous guy. He's kind of, quote, barrel-chested. He's got a lot of that air, lung that's been destroyed, and so he can't expire the air. He gets the air that's trapped, and that's where the barrel chest comes from, and they tend to burn muscle quicker than the guy on the far right, who we might call the blue bloater, the CO2 retainer. His CT might not have an emphysema on him like this guy's might if you had done them, but he might have a lot of the goblet cells, the thick mucosa, the chronic productive cough, still have obstruction on his PFTs, have the elevated CO2. We kind of put them all in the same boat. But on the line, there is no single physical exam finding in the lab that's pathognomonic for COPD. When you think about it, it's really by history. You take a good history, and it's pretty simple, straightforward, and some spirometry, and you kind of piece it together. Well, the spirometry is the one test, and depending how you generate these, you can get various types of curves, and at least the ones in the hospital spirometry, the ones that I tend to see most of, there are a couple of curves. This is going to be called a flow volume curve. That is, flow is going to be your y-axis, volume is your x-axis. So if you're going to have expiration on the upper part, this is going to be a full set of lungs. They get a full set of lungs in the lab, and now the tech is yelling at them, blow, 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 blow it all up, keep blowing, blow, 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 blow. Okay, now suck it in, suck it in, suck it in. So this is the inspiratory limb, and that's how you generate the flow volume curve. This can be used both to give you an idea, is it a quality test, and what pathology might be there. There's also a second curve that I don't have an example for called a volume time curve. Basically, you're going to plot volume of air expired over a number of seconds. And generally, the testing is 10 to 15 seconds worth of expiration. But what I'm getting at for spirometry, it is a test that, to be accurate, it has to be done properly following certain guidelines. It does require patient cooperation, so they kind of fudge it if they want, or try to fudge it, or they hack and spit and cough, and you get crappy-looking curves, and can you even bother interpreting it? My talk is based on the assumption it's done properly and you have accurate data. So if you do, I don't know if you guys are doing spirometry in the office, and actually it's important to make sure that they're going to be quality testing as best as you can. And that's going to be above and beyond trying to teach you that here during this talk. But I know there's, at least on the end of the talk with some of those websites, the GOLD website has got some other access to office-based spirometry too. If you guys are doing that and you say, well, maybe I better double check to see, are we doing this right? What kind of spirometer, or who's doing it in my office, the right technique, getting believable, accurate data or not. So what might this look like in people with COPD where you're mainly concerned about expiration? Their inspiratory part is pretty normal. So that's why the inspiratory limbs aren't even showed here. But what happens as the obstruction occurs in these two and gets worse, airways narrow, you can't blow the flow drops because you just can't. That's the pathology of it. So your flow drops, and you get this concaveness to the curve here, very severe. So flows are low, and they drop off quickly. This would be a very severe pattern in someone in the expiratory part of this flow volume curve. And someone with, just for comparison, someone with restriction, they don't have a problem with flow. In fact, sometimes their flow are super high. They just have really small volume, so maybe that point should be way out there. Instead, they shrink down because they got either chest wall or rubbery lungs that want to contract and flow all the air out. So flow is not the big issue. This, in a different form, you've seen this before, but this is to emphasize. This time it's going to be percent survival on the Y versus years, and then you're plotting percent predicted FEV1. The blue is somebody with normal lungs. You know, they survive for years, but someone who's got less than 30% of predicted FEV1 for that population, they die in a few years. So again, the worse your spirometry is, impairment, quality of life, productive years, and death come. X-ray, that someone perhaps who has the emphysema and the air trapping might look like. Maybe flattened diaphragms to some degree, and I'll show you a lateral. Maybe the spaces between the ribs are pretty wide, should be narrow. Maybe a narrow mediastinum. On the lateral, looks pretty flat here. Normally you would see a dome. Maybe a little too much air. I would say too much, but extra air and large retrosternal airspace. This would be an X-ray of somebody with emphysema perhaps. But it's not pathognomonic, it's not perfect. Now we get into the components of management based on the gold guidelines. Assess and monitor disease, risk reduction, manage stable COPD, and really my talk is the top three. I did not plan to get into manage exacerbations. That could be a whole nother talk on that group of people. The nuts and bolts of it are probably two. I think all these three up here have to do with improving quality of life. Minimize the symptoms. Minimize their impairment would be minimize their complications and exacerbations. Let them do more. Try to prevent disease recurrence or progression. And then, you know, the number two would be reduce the mortality from the disease. How can we do these things? Yep.
I have a question about the disease progression. So I really don't understand deeply about the pathology of the COPD. I know there's a lot of cytokines, and the probability that someone will get a severe COPD compared to another person is very variable. So my question is about the progression of the disease. Is it a kind of linear relationship with that? So for example, like in cirrhosis, you know that it's going to get worse.
It's the curves that I've showed you that had to do with either FEV1 or percent per day. Now there's some more curves that'll come up that'll bring that out. That'll show you what will happen to these people as their FEV1 drops.
It's never actually going to be controlled or contained. It's just going to progress. Or
Generally, it's a progressive disease. But what can you do that affects the progression rate? And hence shift the curve from dying young and being impaired at 50, sitting at home with oxygen on your tube, trying to live longer and being at work longer. Yeah, so generally it's a progressive disease. But what can you do to affect that rate of progression? Stop it, nobody's got that, but slow down the rate. There are some things that we can do to that. I wish there were more, but there are some, and we'll get into that. So quality of life, more functionality is one aspect, and then live longer. That's really how I kind of break up. Isn't that a goal of everything we do in a lot of the diseases, really? Well, the assess and monitor is the symptoms, plus then I threw in the functional status. What can they do now? What can they do after your intervention? Whether they quit smoking, you put them on medications, they've gone to rehab. Can they still do as much? House cleaning, cutting the lawn, making the beds. I mean, you get an idea of that kind of function by just querying them with that. I think that's important. And then the spirometry, with and without bronchodilator, to help establish the diagnosis. And now I'm going to maybe, it's a little unclear, and I'll say more of this later about, well, how often do you do spirometry in these people? The gold guidelines are a little hazy on that. So I'm going to kind of give you my opinion. Do I use it more than once as diagnosis? Yeah, I do. In part because of the curves I showed you, where if I know that FEV1 starts to fall, is the time coming when you're going to talk about their disability and death, and you have to prepare them for that, if you will. Yeah. Plus, if you intervene, can you shift that curve? Can you say, show, and use it as a positive reinforcement that this intervention is helping, your numbers are stabilizing, getting better? Yeah, I can use that too. And there'll be another when we get onto some of the medication usages. If you choose to go outside, quote, the guidelines, can spirometry help you establish, yes, in this patient I used more aggressive medical management than the guidelines suggested, but here's my proof that it helped him or her. Or it didn't help them, so I stopped them. I mean, there's other reasons to do it. Certainly once, and I tend to follow stable COPDers for a while, at least once a year. You quit smoking, they're doing fine, you get 2, 3, 4 years in a row, and the numbers don't seem to change. Then sometimes I offer them to, if they maybe don't want to do it, I'm not going to arm twist them. But I tend to follow them. Just like asthmatics, I tend to follow yearly. Ask me for level A evidence-based medicine to prove that. It's going to improve their quality of care and lessen the cost. That I can't do for you. That's kind of my personal preference. And the GOLD guidelines, if you read them, they're a little unclear about how often you should be doing this. But we talked about some other things. We talked about what do they die from? Cardiovascular disease and lung cancer and respiratory infection. But what else do they suffer from? Osteoporosis. If they get sick enough, they tend to be immobile, lose muscle mass. The second thing is they tend to lose muscle mass, whether it's because they don't eat much, because their lungs are their emphysema is so bad, it presses on their stomach, they put food in their stomach, it irritates the diaphragm, and it's eat or breathe, and they choose to breathe and not eat. Or they're short of breath and they're just sitting. Inactivity leads to osteoporosis, leads to muscle mass loss, almost a vicious cycle. So we probably don't, and then you can throw in the steroids, at least oral steroids on top of that if you use it on people. I also think depression's a big deal. These people feel lousy. If they get sick enough, they can't do what they want to do. They can't they got to quit their job, disability. So I probably think we don't do as much or pay attention or notice as much with the osteoporosis and depression perhaps as we should. And then they do lose muscle mass. And there is some, and I'm not smart enough again to tell you the actual pathophysiology or the chemistry behind why they have increased muscle dysfunction and weight loss, aside, when the ones we used to think about, that they don't want to eat because it fills up their stomach and presses on their diaphragm and hence they don't breathe. That type of, my simple mind can follow that. But there's some other pathophysiologic differences, chemical differences that are seen in these people that leads to muscle mass loss as well. And then if they can't do anything, they're just sitting. So that compounds it as well. Risk factor reduction clearly is there, and number one is quit smoking of any kind and quit passive smoking too. I mean, if they're nowadays, they shouldn't be in work environments where they're smoking, but not too long ago, you could be in a room office where people smoked and you're in there 8 hours a day smoking somebody else's smoke. That ain't minor. I put this on for, it's worth thinking about and asking, but it's a little unclear for the general public, what do you do with environment and occupational stuff? Because the role of cause and effect is kind of smoky. We know exacerbations are there. In some occupations, it might be pretty clear that there is some role. And kind of like with asthma, they're in a certain occupation, they leave that occupation for a week vacation, they feel great, and then they come back and here it is again. Is there that same pattern with COPD? All that's a little smoky, hazy. And just to highlight that cigarette smoking clearly is the number one risk factor. 90% of all COPDers have got smokers. And fortunately, only 15% of smokers develop clinically significant COPD. We'd have a lot more people to deal with. Some would say, well, in the end, both of these ended up on your slide, so the end game was the same. Back to, maybe this is the question, one part that he brought out. Lung function, as it deteriorates, disability happens and death. Well, one thing is, if you quit smoking, that's one intervention where you can both improve functionality because you can shift the curve. That's what quit at 45 means, quit at 55 means. You can also delay death or improve mortality by doing that. So quitting smoking is number one for improving quality, function, lessening morbidity, decreasing mortality in the COPD group. That's one way you can shift the curve, slow the progression rate down so they turn into just someone who close to lose the same rate of lung as we're all going to lose just from aging. And you can't change. But you can slow down the rate of loss and normalize it. In some ways, I kind of use this as you get your lungs back, new lungs, fresh lungs, I kind of use that mentality with them. And some people, whether it's right or wrong, at least the rate is the same, back to a normal person. Their eyes kind of go up. And if you show them the spirometry where there's leveling out or the numbers get better, that sometimes in some people, that's useful. It's a tool that works with those people. And I think we talked about this as well, but this emphasizes, again, that people who quit smoking, their death rate from all the lung cancer, cardiovascular disease, everything else drops to those who are intermittent quitters or still smokers. So clearly, and maybe that's no surprise. Quitting smoking is the #1 intervention in this group. And Steve and Jay did a good topic on the smoking cessation, so I'm not going to say much more about that per se. Well, vaccines are another intervention. At least in the GOLD guidelines, they put them under a topic called pharmacotherapy. There's very good evidence for influenza vaccine limiting pneumonia and death and mortality, and it's not just in COPDers. I mean, in the CDC, I think it's age 6 months or over, everybody should be getting it in the US. And this is actually one where there's some differences between the GOLD guidelines and, in this case, vaccinations. Here's what the GOLD guidelines say for the pneumovax. Although if you look at the CDC guidelines, they're different. I mean, I tend to vaccinate people outside of this too. Anyone with some medical illnesses, COPD, asthma, heart disease, they don't have to be 60, they can be 55, 50, and I tend to push the vaccination or suggest the vaccination. The data on preventing pneumonia, pneumococcal pneumonia is not so good, but preventing the bacteremia, septic shock, dying in the ICU, that severity it does cut down. So there's some differences between the GOLD guidelines, and again, GOLD guidelines are worldwide. There's some other groups within various countries, the US included, who may differ on some of these. And again, influenza, yes, and I say pneumovax, yes, although the GOLD guidelines would differ a little bit as to whom with that. Then there's medical management, but that's on top of what I've just said. Risk factor and vaccines, that covers all stages. Well, what do you mean stages? Well, that's how they're going to base severity. They're going to stage it, and they're going to use the spirometry as part of that staging. But I want to emphasize, I think we got to be a little careful. We don't just get hung up on numbers of spirometry, that you also pay attention to the clinical course of your patient. How symptomatic, how impaired, how many exacerbations, and figure that in the spirometry when you decide your treatment plan. The staging here is listed. It starts out, first, is there obstruction? And that's the ratio of FeV1 FVCC less than 70%. That's the one that they're using. Some people will argue on that. You may miss some people on the bottom end, as younger people can have a ratio that's 0.7 or higher, but they still, because of what makes up a patient population, they still can have obstruction. On the older end of the spectrum, there's some older people's ratio can be lower than that, but still be normal for that age range. But since we're not here to debate what's the best way to pick the definition of obstruction, this is probably the best, safest way to do it. And then it's what percent predicted is the FEV1. As that diminishes, you start going into stage 2, 3, and 4. There's no more stage 0 like there used to be initially. But then you have this slide that kind of puts together the stages, post-bronchodilator spirometry we're talking about, and then the therapy. And I guess I just want to emphasize that we be careful that we don't just say, okay, because this one's 50 and not 49, you can't do this one. You got to think a little bit on here. The vaccinations, risk factors for everybody, the short-acting bronchodilator, usually albuterol for everybody as needed, kind of like the asthmatic. But then they say when you start to get to moderate or worse, everyone should be on maintenance medication, either a long-acting, one or more, bronchodilator, and we'll talk about what they are now. This is one disease where you can use the long-acting beta-2 agonist by itself. You don't do that in asthma because there's a death rate with that, but in COPD you can do that by itself. Or you can use the anticholinergic. They talk about rehab, but then they say, well, when your FEV1 hits 50% or less than 50%, 49%, not 50%, you can think about inhaled steroids if they have repeated exacerbations. Well, does that mean you got to watch them for a year or 2 or 3 to count up, and how many is enough? They don't. So the guidelines have a little looseness with this, and that's why I say if you got someone who has a lot of symptoms, is really impaired, can't do his job, can't function, and his FEV1 is 50%, and you do but say you did a beta-2 agonist in the office, and he reversed some, but not totally. Well, maybe there's more inflammation going on in this guy than meets the eye, and he's terribly impaired. I think I'm going to pick one of these, and I'm going to give him inhaled steroids at the same time. I'm not going to wait because he missed it by 1 percentage point on this scale that I can't do it. That's what I want to emphasize with you. I think you got to use some judgment. And then but in COPD, sometimes it can take a couple of months of use of these to maximize their benefit. Asthma is a little bit quicker sometimes when they respond, but COPD, you might have to treat them for a couple of months on these common combinations to really see maximum effect. If you bring them back too soon, you might short sell the success of the treatment. And then you can look for, is oxygenation or desaturation a problem? I don't think you have to wait till the FEV1 hits that number to check them. If they look bad in the office, you can put it, if you have an oximeter, you can put it on when they're sitting, or you can walk them in the hallway if you think, hey, there's more going on here, and there's no reason why you have to necessarily wait for that. And then we'll talk about surgical treatments a little bit later. Well, what are the agents that we use? The short-acting ones, the beta-2 agonist, is mainly albuterol. I think pure albuterol may still be around out in the community there, but it's really albuterol. I think that's also called salbutamol in some places. The only short-acting anticholinergic I know of on our market here is ipratropium. And then, of course, you have the combination that puts these two together. And I try to stay away from generics. That's why I'm not using those names up here when I'm talking. The long-acting inhaler are usually salmeterol, formoterol. And again, these are pretty much, it depends if you're a discus or an MDI. Is it 1 inhalation twice a day or 2? It depends what formulation you're going to use. But usually these are twice-a-day dosing. That's usually, that's basically a spin-off of that you put in a nebulizer that's twice a day. So that's the nebulized formation. And then Indacterol is a long-acting beta-2 agonist that just came out in the last few months. I think it's 1 inhalation once a day. I have yet to prescribe it, but I think it's just hit the market in the US. And long-acting, I mean twice a day versus, or once a day. And tiotropium, as I think, is the only anticholinergic in the US. That's 1 inhalation once a day. That, I think, is 1 inhalation once a day. These are twice a day, either 1 or 2, depending which one you're using. So they're convenient, they're long-acting, compliance comes into play. They tend to be used more than, albuterol, which lasts 4 hours. I guess if you gave that every 4 hours, and ipratropium 6 to 8 hours, you gave that 3-4 times a day, you could match these things, but that's a lot of usage. They're cheaper because these are generic, but that's a lot, and the compliance comes into there, and almost nobody does it that often. So these are the ones generally when you're talking about stage 2, 3, and 4, you're talking about one, or can you combine them? Because are these different? Yeah, might there be benefit to adding a beta-2 agonist and anticholinergic? Yeah, there is. There's some data to say you add the two together and you improve more though than one alone. What about methylxanthines? Well, the gold guidelines generally poo-poos the that's theophylline, essentially. They say, no, there's no role for that. I say you got to be a little more open-minded than no, there's no role for that. Or pick your point. I mean, they do have toxicity, there's no doubt, so you want to be careful. But I don't think saying no, you can't ever is necessarily the right way to approach it either. And I got to admit, the gold guidelines probably isn't going to say quite no, you can't ever, but they really downplay it. They do say, though, for the leukotriene antagonist, that's the montelukast, seroflucast stuff, no way in COPD. Well, probably if it's true COPD, quote unquote, and that's all you think is really there, makes some sense. But again, if you got this, well, wait a minute, is this a smoking asthmatic? They got a really nice, 2 puffs of beta, albuterol, and the spirometry really got better a lot, maybe not normal. Maybe I'll try the steroid, but if they still have some symptoms, and sometimes you bring them back after you put them on the steroids and the beta agonist. Now, in steroids alone in COPD, you didn't see anything up on the slide there, so it's going to be a long-acting bronchodilator, steroids on top of it. You aren't going to see just steroids alone in pure albuterol. That's not the way you treat COPD. So right? And I'll show you that slide again that's one that puts it all together. So if you got somebody on, say, salmeterol and a steroid, you bring them back, they still have symptoms. You decide, well, I'm going to do another spirometry because I used this a little earlier than what the guidelines said, and you find out that you start out with their spirometry that equals their post-albuterol the first time before you put them on the treatment. And they still get better, but not quite the same. Well, why not think about some other alternative? Or boost the steroid, or if you decide I don't want to do that, maybe this is really an asthmatic who's a smoker. Maybe there's a role for this. Well, I think you can try that. You may then want to document over time. Yes, it does help them subjectively and objectively, and that's where I may repeat some spirometry since I'm going outside the guidelines now and I might use some of this in somebody. I might want to try to prove that it's really helped them get better. So if the accountable care organization or some payer comes to me, why are you using montelukast in someone with COPD? I can go, well, here's why I did it. But I think we're all thinkers in here. We can't just be rote textbook, just do this. I just don't think that's the way you want to practice. Yes, evidence-based guidelines and care standards are going to be out there, but I still think there's got to be room to think, as long as you can defend yourself. Just to anticholinergic, muscarinic, and there's at least 3, and there may be more receptors that by now, and who knows. The essence, you think about it, is relaxation of the smooth muscle so the airway opens. Well, that also can affect secretions. It's a drying agent, so it might be helpful in your sputum producers. The beta-2 agonist, again, working this mechanism, you would think it's to relax the smooth muscle. but we know beta-2 agonists may have an anti-inflammatory property to them. They may actually help cilia work better. Those specific things have never been shown in studies to be why they help patients, but we know they're there, and maybe there's added benefits. Theophylline, the one that the GOLD guidelines said, nah, not on COPD. Again, we think of it as a bronchodilator, but there's some evidence of anti-inflammatory property. There's some evidence that it helps smooth muscle function better, the respiratory muscles, different from this mechanism. So can it be used in some people? I still think you can think about it. What about steroids? The one they say no-go is not long-term oral, not that prednisone 10 a day, 20 a day for the rest of your life. No role for that, they'll say. And in general, I would agree with that. Then if you ask, do I have anybody who is on steroids daily? And the answer is, yeah, there are some. Have I put them on there or have I inherited them? And I have to stop and think. I really don't want, if you've managed people on steroids long-term, you've seen the mess that can happen to somebody. So you really, if you're going to do that, why? Or then you go, is this really a COPD, or was it somebody asthmatic who turned into a COPD, or why the steroids help? They're tough, but there are probably going to be some you're going to struggle with on that. But the GOLD guidelines would say no. Exacerbations, yes, a couple of weeks, short-term, long-term, no. Inhaled steroids, there are at least these many on the market. Maybe I missed some. I'm getting to the point like ACE inhibitors and cephalosporins. I can't remember all of these. What dose, how many inhalations, there's some of that that's I just can't remember. But I do know that in COPD, you're not treating somebody with inhaled steroid alone as a maintenance medication and pyranobutyrol. This is going to be in addition to a scheduled long-acting bronchodilator. And the data for that, I know I'm pretty comfortable in the data that's showing these combinations to be effective. So not 500 of fluticasone or not more budesonide. But these kind of combinations are where they seem to be, data seems to support it for COPD. And I've seen a little pushback from some of the payer sources when you start going above and beyond it. So say, wait a minute, you're calling them COPD and you put them on to 5,500? Why? And you got to kind of fight. And that's maybe, but if you have good evidence for why that is, they subjectively got better, and here's the spirometry on a 250, here's the spirometry on a 500. So you're not going to let them get it? I mean, that's kind of why I do that. But this is also, so how much triamcinolone do you have to use? I don't have that answer for you. I'm not sure that's even out in the data. Some in beclomethasone, maybe it's there. Is there anything else besides inhaled steroids? Well, just recently, romfluminilast, which is a phosphodiesterase 4 inhibitor. Theophylline is a phosphodiesterase, which one is it now? 5 is a sildenafil, I think, sildenafil. I forget what, is it 3? Yeah. So it's a different phosphodiesterase inhibitor. Just out on the market again the last few months. I have yet to use it in somebody, but I'm glad to know something's there, but extra. But who would you use it in? And I think it's generally in the person who has a lot of exacerbations, whatever a lot is. Is it 2 a year, 3 a year, 4 a year? There's no, that's blurry when you read this stuff. More than 3 or more times a year, I think you start looking for other stuff, because that's a lot of impairment. That's kind of my cutoff, at least. That's failing the usual therapy, which might be the inhaled steroid addition if you go to that one diagram, or antibiotics, oral steroids repeatedly. You might think about using it. But psychiatric illnesses, the suicide and depression and all that is a side effect. Don't use it in liver failure or liver injury, cirrhotic type patients, and it can have GI side effects. So you got to pick your poison here when you think about it. What group might you use it in? But it's there. Other agents and stable COPD, again, not the exacerbations. That's the mucomyst, guafenicin, robitussin. There's others on the market, not for the stable patient. For the exacerbation, that's different, symptomatic. What are the general benefits? Well, the bronchodilator, in general, it improves quality, functional, in spirometry, although that's not a gimme in everybody. However, it doesn't slow progression of disease per se. And it's only recently, and some people will still debate whether the combination, this is the beta-2 agonist, so it's not tiotropium, I think, at this point. It's the beta-2s, but steroids. There may be some reduction in mortality compared to the groups that aren't on it. So maybe we now have a second way to intervene. A little smoky yet, and people will argue. Besides quitting smoking, here's one way you might be able to decrease mortality in some people. And then the question I raised earlier, do you do spirometry more than just to make a diagnosis? Well, I do it yearly to follow them. The curves, the impairment, death. I do it under intervention. Certainly if I start to go outside what's considered a guideline, because someone might question what am I doing, I'll tend to do it. And usually I'm just doing spirometry for that. And I think sometimes, as long as it can help in interacting with some patients. Some people like numbers and look at graphs and like, whether they understand all of it or not is maybe not, who knows, but maybe that's not the point. Just, am I better? Am I worse? And it motivates them. Then there's, PFTs is that's a general term. There's all kinds of tests that we do in the lab. Spirometry is only one of them, but there's something called lung volumes and diffusing capacity you may or may not order from time to time. The lung volumes, I might get those if in somebody who I do spirometry and wait a minute, I look and they have both a restriction and an obstruction. You can get a mixed bag here. Lung volumes are helpful to sort out restrictive lung disease, so that's the one group where I tend to use them. The diffusing capacity, well, that is kind of it's a poor man's look at the reflection of what's the quality of exchanging oxygen, air to blood, and carbon dioxide the other way, blood to alveoli across the tissues. Generally, in people with COPD emphysema, that's abnormal, low. To some degree, it all depends on how bad. Generally, it's not normal. In asthmatics, it's usually normal. So if you got somebody where you think it's COPD and you happen to order one of those and the spirometry comes back as normal, you may have to step back and think, is this really COPD? And rethink your diagnosis. What about rehab and oxygen in terms of therapy? Because they're on the one slide. Rehab, evidence A, in just about everybody, stage 2, 3, and 4, to improve functioning. It isn't going to slow disease or decrease mortality, but they'll function better. Hypoxemia, in those people who are the less than 55 PO2 at rest, so really the severe group, mortality is decreased when you give them supplemental oxygen. It's a third way you can intervene on improving mortality in these groups. And just a slide to emphasize that in this particular study, dyspnea and walking distance, this got less, this got better. This is what we call the stage 2. This is the monitored where you're in the facility or in the program, and it's usually 6 to 12 weeks, 2 to 3 times a week. And it's not just plunking somebody on a treadmill and walking them. It's also talking about their disease, the psychiatric, emotional side of it, the anxiety, control of your dyspnea, the diet, the medications. And if you're in there with a group, you're in there with a support network. And then for this, of course, to be maintained over time, they got to do the maintenance phase, and that's all on their own. This usually gets covered by insurance. The maintenance phase doesn't. Oxygen. As I say, those who are really severely hypoxemic, you replace it, you can improve their survival, but one thing is it seems like when people look in the mirror, they see this. They don't like this. They don't like the way this guy looks. They don't want to use it because they don't want to be one of these guys. But if they're that severe, though, and you can improve their survival, and yes, you can improve functionality, too. And that's also true of those who are fine at rest but desaturated with activity. There's some data that say by supplementing them, you'll improve their functionality. Medicare pays for it. Survival, not necessarily. There's no data on that subgroup. So part of it's battling through the psychological aspect of it. This puts together 2 studies, one from Britain, one from the US. Essentially, survival and time. This was oxygen continuous 24 hours a day. Well, actually, it turned out 19 hours a day. People didn't keep it on all the time. Their survival rate was better. Separate study, this was from Britain. This was 15 hours a day, 12 hours a day, and none. And these were again the severe hypoxemics, the under 55 group. Basically, oxygen around the clock survival better than 15 hours, 12 hours, 0. So essentially, you try to get them to use it all in that severe group all the time. And they may have to do more if they exert themselves. And then there's the group of people who are fine at rest, but with exertion or SATs drop. And then you try to figure out what O2 they need to keep their SAT at 89, 90% with activity, and that's what you prescribe them. It gets covered. But I'm not going to be able to show you survival data on that. Is there surgical interventions in a very small group of people when you've got these big blebs and bullae that take up a third or a half of their chest? Occasionally they go to the operating room and have those removed, so quote, what lung is left can use the space appropriately, but that's a tough, I don't know, have I done one of those, 2 of those in my lifetime? It's rare bird. Lung volume reduction surgery, you've heard about, that comes from in that trial, the National Emphysema Treatment Trial. Essentially, Medicare pays for this in the subgroup of people who have emphysema in the upper lobes, have a certain decreased exercise capacity, and the study had, they bicycle these people, so they had a calorie or watt definition, and they Medicare will pay for these because both mortality was lowered, functionality was improved at least for 5 years, 2 to 5 years. In the other subgroups, mortality was not affected beneficially compared to medical treatment. Everybody functioned better, but what drove it is a combination of this. So Medicare said we're only going to pay for it in the subgroup and only at centers that do the transplant or associate, and therefore I don't know how many people I've sent to be looked at for this, but I can't think of one of my patients who actually had it done. So it's a rare bird too. And then there's lung transplant. Well, lung transplant has its issues too that I'm going to talk about briefly, and then we'll wrap up for questions. But another reason why get spirometry on some of these people, when you start getting that 25, 30% predicted, are they getting to a point where you got to start raising the question? And you don't have to have all of these, some of these. Is the time you start talking to them about other treatment options, including new lungs? I mean, you bring it up to them. I think you need to somewhere in there, whether you guys want to do it or then you refer them to pulmonary at that point in your call. So there's another reason why I think paying some idea to where their functional status is important, as well as, the blood gas and their O2 saturation and all that stuff, because there might be a treatment, because there's a waiting list, for COPD. Well, is it the magic bullet? No. And why is that? Because when you compare lung transplant, the overall survival for lung transplant, all comers at 5 years is 50 to 60%. The problem is with COPD, you can't really know for sure on an individual who's going to be alive and dead with their COPD in that time frame. They might be impaired and not do what they want to do, but it's really tough to nail where do those lines cross from survival. You're better with transplant than sticking with your native disease. So medically, that's standard of care medical management, questionable survival advantage. 2 lungs are better than 1 lung, and if you're going to transplant these people, their survival's better, but what's the trade-off is, cut down by half the number of people who get transplanted. So that's not a panacea. It's there. This is probably the #1 disease I refer the most often for transplant. There's some who get it. There's others who say, I don't think I want to do that. Maybe I can't walk as far, but you're telling me I might be dead in 2 years after my transplant, but I got grandkids. I might want to be here. Maybe I'll have just as good a chance of being here with my COPD as it is than not. So it's a tough call. Back as a summary. Again, the staging, but I think, yes, the spirometry is important. Good studies, accurate studies, post-bronchodilator, so I'd probably do pre and post on these people so you get them both. But you got to put in the clinical picture. How impaired are your people? What kind of symptoms? How many exacerbations? And then this is the algorithm they suggest or they state, but I mean, again, I think you can vary here a little bit on these if the patient's sick enough. You just be, like anything, be ready to explain yourself when you treat somebody a given way. Summary, suspicion. The smoking history, the symptoms, especially if, I'm coughing more now when I'm coming in. I think I got a chest cold, but God, I've been doing this for 5 years. Well, buddy, there might be more going on here than just your chest cold. Spirometry, as we talked about, and like anything, you want to make sure that there's not another disorder on the list. And then the fourth thing, which I didn't talk about, but which is important, is how do you manage these people when they get flares, exacerbations. And then these last slides, and I'm just going to flip these up quickly. These are all various other websites you can go to for reference data. Here's like a sample action, kind of like asthma, asthma action plan. This is one for COPD. Here's the one I had up before, and I know under this there's some separate additional websites or material that has to do with spirometry in the office, if that's relevant to you guys. And then there's a whole array, and there's some more here on smoking cessation that Steve probably's got in his handout. And that's the end of it. So I don't know, any questions? Yeah.
For your management for COPD, do you usually start first with the short-acting, and if they're not responding, they're exacerbating again, start with because what I do, I combine right away with the fatigue.
Usually, if they have obstruction on their spirometry and no symptom, there are somewhere you're looking that's pretty severe obstruction, but they have no symptoms. You say, no, I'm doing everything I want to do. Then you look at what this says. Well, okay, say it's stage 2. Well, they should be on one of the. I talk to them about what is suggested, and that maybe they can actually do more than what they're telling me, but they've taken a while to settle down to this functional level. That if they get on the medication, they might notice a difference. But there are some who go, I feel great. I really don't, want to take a medication twice a day, once a day, because I'm doing everything I want to do. So I don't force them. I still suggest that the PRN rescue stuff on all these people. Usually, though, by the time they're stage 2, they have some symptoms. And stage 2, 3, that's 2, 3, 4. I think that's, the numbers are important, but there are some people that can be a lot worse functionally and symptomatically with numbers that are better than somebody else who can have worse spirometry but don't have as many symptoms. So then I think usually in those cases, with some symptoms, I'm usually talking about either a bronchodilator singly or with a steroid. But sometimes by the time I see these people, because they might have been to you and you might have referred them already, there's some issues. I would say half the time I'm talking about the long-acting bronchodilator plus a steroid right off the bat on these people, or adding in the tiotropium to the salmeterol fluticasone. You guys already have them on, step therapy.
So even if they're moderate, you can add all three of them, the fluticasone, salmeterol, and the tiotropium?
You could. If they're, moderate, the stage 3, 4s, and they're symptomatic, as long as you follow them and you bring them back, you don't just say, okay, take all this and come back in a year. You take all this and let's see you back in 2 to 3 months and let's get a spirometry. Let's see what happened. If they're feeling lousy, isn't our goal to get them better as quick as we can? But, make some sense that, because there's toxicity. I didn't talk about complications. And the ones, that might come to mind are the inhaled steroid and beta-2 agonists. There is an increased incidence of pneumonia in some of these people. So if you do that, quote, outside the guideline, do you want to do the spirometry? You bring them back to prove the benefits. Well, yeah, you should. I think you should do that if you go outside guidelines in general. You should try to document why you're doing it. If it doesn't work, then you get them off of it. You don't just leave them on it. It's tricky when they say, oh, I feel great, but their spirometry doesn't budge or change much, because that can happen. Then you got to go, well, do I or don't I? And that's, again, judgment on that. But my tendency is to treat people aggressively. More medication, offer it at least to them earlier on this curve than what they say. Some people do want to do it, some people don't. Some people, I don't want to take 2, 3 different inhalers. I'll take one, and that type of stuff. But then I follow them, or at least I try to bring them back. Now, sometimes they come and sometimes they choose not to, and they say, well, I keep coming back to the doctor's office. And I try to explain, here's what we're trying to do. We want to get you feel better, and if you saw the numbers get better, then sometimes their eyes open up a little bit too. Oh, hey, great. And you can, again, if they're smokers, that's another opportunity to talk to them about quit smoking. You can touch base on that too. Yeah, Mike?
Can you look at the spirometry and identify those patients that are going to probably survive a bout of intubation?
Actually, for all, there's a little, somewhat related. You go, well, they're going to have a surgery or something. We got to get spirometry, see what their lung function is. The only time spirometry has really helped said, yes, you can, no, you can't. In terms of surgery now, maybe a little different than, but related, because it's the complication, is if you're going to have a chunk of lung cut out for one reason or another. Lung cancer is what you think about, but then occasionally other cases, or transplant. Everything else, the spirometry can be terrible, but they can make it through. Will they be at a higher risk if their spirometry is worse, or their PCO2 is elevated, or their PO2 is low? Yeah, but to the point where I'm willing to say, no, you can't have that surgery, because that's the best way for you to get cured from your cancer of the pancreas. But it's a 3-hour, 5-hour Whipple or whatever. I don't tell them that. I just tell them your risks are going to be high, but you weigh those things off. Same thing for intubation stuff. You get a gut feel, because that's what I talk about. If you have this procedure and you're this bad, your risk for complication, here's the complications of which ventilator is one. But I tell you, I can get a gut feel for mild, moderate, high, but don't ask me to give you a percent. I can't, because we don't have the data on that. So no, there are some people where you look at their numbers and you go, my God, they went and they had, whatever, the Whipple, the colon resection, the bypass, and they got off the vent the same day and they sailed through and went home in a week. They can do it, but they're more like, just as likely you're going to have a few more of those that didn't quite make it off, or they made it off and they got re-intubated, or they're in the hospital 2 weeks because they struggle. But I'll never say never. It's more a gradation. And what is that other therapy or that other process that you're offering, and what's it going to do for them? That gives them the best chance to survive whatever other disease they have, or get better. You get them in the best shape you can be to minimize the risks. Let them know what the risks are, or the surgeon, anesthesia as well, and then you make a joint smart decision. Here's what let's do it, or no, I don't want to. If it's a cosmetic surgery or something that's then I get a little more, paternalistic, if that'd be the word on it. But otherwise, it's here's what you're facing, but you don't go through with this, and this most times it's surgery. What's going to happen to you? Well, shit, I'm going to die in 3 months from, or 4 months, 6 months.
I mean, what about the guy that gets pneumonia? And, it's 11 at night, and, you've got to advise the guy and his family as to whether you want to intubate him and, have him die by inches on the ventilator.
I think that comes down to the more global discussion of, and it always works better when you know the people and you've been seeing them. It's, Joe or Sally, whoever, what's your perspective on life and resuscitation and doing aggressive intervention and taking these risks? If you've got that settled, these decisions come easy. And some people, but oftentimes not. And the way the healthcare system is now, you've got inpatient doctors, you got outpatient doctors, clock punching shift in the ICU, we got 7 a.m., that connection is lost. You still try to have a discussion, but the real meaning is quite there because the relationship isn't established. You still talk about it, and if they say, "No, do everything you can," well, then you go for it. And they always try to, but at least when I'm there, I say, but it doesn't mean at some point we can't rediscuss that. Do we still want to continue this way? Maybe for now we'll start, but maybe at some point we're going to say, where are we now? Do we really want to keep going, or is it now time to rethink and back off and withdraw, whatever, on these people? But they can surprise. Some of these COPDers, and you look at the numbers that I put on the graph, and you said, this guy, Joe, you should have been dead 5 years ago. How come I'm still seeing you here 5 years later? Well, because they're still here, which is also why, transplant. Well, he went to transplant. He might not be here 5 years later. He might be one of these 50% mortality people. So.
I see some patients on Convivent, ipratropium, albuterol as maintenance therapy rather than as needed. I don't know what's the value of that, comparing them to putting them
You could use that,
short acting.
Yeah, and so you go, well, if you're going to follow the thinking about you want to get them on scheduled medications, you don't want to have the roller coaster effect, 4 hours, 6 hours, well, then they should be doing that 4 times, every 6 hours, 4 times a day, a couple of hits. And you can say, well, because there's a generic form of that and it's cheaper than them having to go buy tiotropium and salmeterol. Well, there are some like that where they don't have money. They don't have insurance. And none of these long-acting are generic. They're all on patent yet. The short-acting ones are generic, but you can. And there are some where I do that. And there are some where, they have Medicare Part, they don't have prescription, but they have Medicare Part A and B. So if you do nebulized medication, not the can, nebulized, Medicare can help pay. Will help pay for that. Well, I'll do the nebulized, do the ipratropium plus albuterol, or I might throw the budesonide, which you can get in a nebulized form. I might do the nebulized combo because they're that bad because they can't pay for it, but through Medicare, because don't ask why Medicare does it, that's just the way it is, they can get some payment for it. And then will they do it? Well, that's another story. Do patients do what you want them to do? That's several factors, yeah.
Recent evidence that beta blockers can help improve the mortality rate.
Beta blockers and COPD,
Just a very recent article.
I think I skimmed something like that. I can't comment on that here because that would go against what we talk about beta block. Now, if it's beta blockers because they have high risk of heart disease and you're limiting,
The argument is that beta blocker and COPD only. So even though patients do not have cardiovascular disease, or there's a great study published in the British Medical Journal.
yeah. I remember hearing about it, but I haven't read it in detail. I really can't.
Cohort study. So
Yeah.
I think we cannot just say, oh, you have COPD, I'm going to start you on a beta blocker.
It raises, it's another question.
One of the theories that it could be it play a role in increase the receptors of the beta.
I think there's a lot of stuff we just don't know yet.
The beta agonists that they are on. So.
We'll see. It's the same thing. Well, you shouldn't use beta blockers in asthma. Well, you're cognizant of those things that can happen. Same with COPD. But why are you using them? And sometimes you do. Now, as a therapy for COPD, we'll have to see. It isn't certainly front line at this point. But yeah, when you brought it up, I remember reading or seeing that a little bit. I haven't done any in-depth reading on that though. Yeah.
In the
Yes, most times it's going to be a beta-2 agonist. Now, in some labs, and I'm not sure on the IU system, and now this system's gotten so monstrous, I don't even know, can't even dare speak for it. At least when it used to be IU hospital, in the VA, which is, of course, isn't IU Health, and you could ask for ipratropium as a specific request, but they wouldn't do it routinely because the beta-2 agonists are quicker onset. They don't last as long, but they're quicker as a rescue than the ipratropium. Takes longer onset. But some have done it to see if they have. Now, what's the evidence for reactivity with that anticholinergic, meaning you should use this medicine instead of this? I don't have that. But some of my colleagues have asked for it, and we've done it. Yeah, the lab has to know ahead of time because A, they have to get it, and B, they have to wait longer between when you bring them back to repeat the spirometry. Now it's usually peak action for albuterol is about 30 minutes, but in the lab we wait 15 or 20. So we try to get some effect, but not peak. You guys got to know that. Ipratropium is what, 45 minutes, an hour, or something, but nope. No lab wants to have somebody sit around for an hour waiting to do another spot. Now you come into logistics, but it can be done. But almost off the top of the head, it's going to be albuterol.
I don't know if you've done that with, they don't like it, they're jittery.
It's something, yeah.
Something different, and I just change them, but I've never documented that.
But in this thinking of the treatment, you probably wouldn't have to document. You could say some of my colleagues, I think they're doing it more out of academic interest, and it's doable. But yeah, some people don't like and then you can say, well, what about the, I don't want to use the trade name, but I'm going to have to. It's the Zopanex. That's the isomer. I think it's all L or SI. Well, I don't know. It's there. I didn't list that separately as a beta. It is a beta-2, but it's supposedly only a single isomer and doesn't have the side effects, or so it says. Some people, that's true. I mean, some people notice a difference. Other people, the data would say maybe it isn't quite as true as the company wants you to believe, but something that's out there too. And that's not generic either. That's on patent yet, so it's costly. And I think if you use that selective one, might have to explain yourself if there's a payer source as to why you're doing it. Failure of the standard, 2-isomer albuterol stuff or CMIC mix. All right, thanks.